live for everybody.
Yeah, go for it.
And I'll just enter full screen. Can everybody see the pharmacology PowerPoint?
Oh, yeah.
Fantastic. Okay, well, let's process our way through it. And then what we'll do is we'll open the forum up for general questions. So when we talk about aspirin, aspirin comes from salicylate, which can be found in plants such as willow trees and myrtle, and it's actually been used in its purest form for over 2,000 years. It's a commonly used drug for the treatment of pain, fever, inflammation, rheumatic fever, rheumatoid arthritis, and the prevention of blood clots. It is an analgesic, it's an anti-inflammatory, it has antipyretic effects, and it does inhibit platelet aggregation. So in general terms, we do use it for quite a variety of illnesses or injuries within the pre-hospital and hospital environments. Oh, it's not wanting to go through. It's classified as a non-steroidal anti-inflammatory drug, and quite often you'll see the breakdown of that term, or the shortened term NSAID or NSAID. It works by inhibiting an enzyme called glycooxygenase, or COX for short. Glycooxygenase is present in two forms, and those forms are COX1 and COX2. When we look at those forms, COX2 is responsible for inflammation and fever, and COX1 protects the gastric mucosa from the acid the stomach naturally produces. It also plays a role in making the platelets stick together to form clots. And you'll see when we look at the actions, the adverse effects, and the contraindications of aspirin, where that all fits in when we talk about COX1 and COX2. So cyclooxygenase is crucial for the production of prostaglandins. And prostaglandins are hormone-like substances released in an inflammatory response. They are released at the site of injury, and they're created by the cells that are injured or damaged. They cause inflammation, pain, and fever, and they do this as part of the healing process. They also stimulate the formation of a blood clot to try and heal damage and cause muscle wall contraction to try and prevent blood loss. And again, this all ties in nicely when we start talking about adverse effects, contraindications, and actions. You'll see that it all comes back to a lot of what we're talking about here. So NSAIDs, or non-steroidal anti-inflammatory drugs, work by blocking the action of cyclooxygenase, and so therefore they actually reduce prostaglandin levels at that site. There is two classes of NSAIDs. There's non-selective and selective. So non-selective NSAIDs inhibit both types of COX enzymes. So this is the COX2 and the COX1 that is inhibited. And examples of non-selective, non-steroidal anti-inflammatory drugs would be aspirin, which is exactly what we're talking about tonight, and ibuprofen. And they would just be two examples of non-selective NSAIDs. Selective NSAIDs inhibit only COX2 enzyme. So they actually allow for the production of prostaglandins, and while they still reduce pain, fever, and inflammation, they actually have no effect on the clotting. And two examples would be Celebrex and Mobic. So when we look at aspirin specifically, it actually has several actions. And we see this, it's written on the pharmacology listing that we've sent out to everyone. So this is the type of thing that you guys are starting to study at the moment. So it inhibits platelet aggregation, it suppresses inflammation, it reduces fever, and it relieves pain. Now, we don't necessarily use aspirin for all of those actions, but we definitely use it for the top action, which is inhibiting platelet aggregation. However, you might work for an organisation that uses aspirin to suppress inflammation or reduce fever or combat pain in a patient. It is an antiplatelet agent, as I mentioned when we talked about inhibiting platelet aggregation as an action. It's rapidly absorbed in the stomach and the upper intestines. It absorbs into the bloodstream and it's transported around the entire body. It only works where there are prostaglandins being made, and that includes the area where the injury actually is. The half-life of aspirin is 15 to 20 minutes. Okay, and I just can't read this bottom bit, unfortunately. Let me just go back. I can't see it. Can anyone see that very bottom?
No. No.
Are you talking about the last line, the inactive?
Yeah, I just, it's my...
Oh, so the platelet inhibitory effects last the lifespan of the platelet as aspirin irreversibly, go back, inactivates COX-1, which is the human lifespan of the platelet is approximately 10 days. So it's talking about the reduction in what the body's capable of doing on its own without the introduction of aspirin.
Sorry guys, can you guys still see the screen?
Yeah, we can.
Yeah, it's all good, clear.
I can't see it at all.
It's
Peter, can you continue on for me until I...
oh, it's gone now.
Now reopen it, Belle. It should be fine.
Let's try again. Sorry guys, I don't know what happened. It just literally went from me.
You use an Apple, you'll be right.
It's all you guys that are using Apple that's my problem. It's affecting my computer.
There we go.
Okay.
Something's happening. There we go. That's the start again.
Excellent. So if I enter full screen again, yeah, I've got it back. Can you guys all see it?
Yep.
Fantastic. Yeah, so as I think Kenny was saying, is the inhibitory effects that are that the platelets undertake, they actually last the lifetime of the platelet itself. So when we give a patient aspirin, it is an antiplatelet agent, and that platelet doesn't have the ability to clot at any stage during its life cycle. So that inhibitory effect lasts the life cycle of the actual platelet. I don't know why it's doing that. Okay, so the indication for use of aspirin, and again, guys, this is based on paramedical services pharmacology. Our indication for use is a suspected myocardial ischemia. So while other organisations may use this drug for pain and fever, we actually only use it when we have a suspected myocardial ischemia or an acute myocardial infarction, suspected, of course. Why do we use aspirin for an AMI? An AMI causes or is caused by complete occlusion of a coronary artery. So a thrombus occurs at the site of a plaque which is ruptured, and because of that rupture, we're getting exposing of the inner core of the artery, and thus thrombus formation is starting to occur. So because we've got exposure of the artery, as far as the body is concerned, we have an injury there. We have an insult to the actual artery, and therefore it is undertaking hemostasis, where it's actually starting to fix the actual site of injury. And one of the things that we do when we undertake hemostasis is to actually form a clot at the site of injury. So as the myocardium is damaged by a reduction in oxygen supply due to the obstructed coronary artery, the treatment is aimed at reducing the extent of myocardial damage by reducing platelet aggregation and limiting clot development. Guys, has anyone got any questions around that?
No, doesn't look like it.
Take that as a no.
Excellent. Okay, so just to reiterate, we've got an insult to the inner component of an artery, and because of that insult, we have platelet formation occurring, and as that platelet formation continues, the bigger it gets, the greater the blockage that occurs in the artery. As that blockage increases in size, the ability for oxygen to get through is going to decrease. So we use aspirin to inhibit those platelets from aggregating and reduce the actual size of the clot and limit clots from actually developing, therefore allowing the heart to receive the oxygen that it needs to continue to do its job. So the time of action is around about 10 to 20 minutes, and it really depends on the size of the patient, the weight of the patient, whether the patient is male or female, if they've eaten and when they ate last and what they ate last, because that will all affect the metabolism of the actual drug. So we're looking at about 10 to 20 minutes for maximum platelet inhibition. Oh, wait there. Come on. So there is some adverse effects to giving aspirin, and an adverse effect is something that may happen as a result of giving aspirin. It doesn't mean it will happen, but it may. So it is something that we definitely have to consider before we give the aspirin to the patient. We have a few listed in Paramedical Services Pharmacology, and these are ones that you should be learning. We have allergic reactions, and allergic reactions can be anything from asthma to anaphylaxis. It could be angioneuritic edema, such as swelling. It could be laryngeal edema, again, swelling of the larynx, urticaria, rhinitis, so we've got hives, runny nose. So any type of allergy that the patient may have, we will get an allergic reaction if they're allergic to aspirin. So very important that we're asking them if they've ever had any allergic reaction or if they have any allergies to any type of non-steroid or anti-inflammatory drugs. Another adverse effect can be aggravation of bleeding tendencies. And again, when we look back at the actions of aspirin, one of those actions is to limit clot development and limit antiplatelets coagulating. So if a patient is bleeding or they have any type of bleeding tendencies, if we were to give them aspirin, we would aggravate that. So definitely something that we're not going to give. Gastric irritation and indigestion is a side effect or an adverse effect, but it is quite unlikely with only one tablet. And this is all we're going to give is just one tablet. Joint pain, because of the release of uric acid, is an adverse effect. So quite often patients that are on aspirin may complain of joint pain. And it is also associated with Ray's syndrome. Now, Ray's syndrome is a very rare disorder. It's a disorder that causes brain and liver damage, and the reason for that damage is because of the swelling that actually occurs in the liver and the brain. It is mostly seen in children, and it's mostly seen in children that are recovering from a recent viral infection. Now, they're not 100% sure of the link, but they do know that aspirin greatly increases the risk of Ray's syndrome, especially in children. And when we look at the contraindications, one of those contraindications will be around age, and we can draw it back to this adverse effect. So quite important that we aren't giving it to children under a certain age because of Ray's syndrome. Okay, so aspirin interactions. What aspirin interactions are when we give a drug that can actually make another drug less effective, or the combination of the drug that we give to the patient along with other drugs that they're already taking could increase the risk of effects to the patient. So a few of those that I've listed are other types of anti-inflammatory medications, and that's because they increase the risk of stomach bleeding. There's also a medication, and I've tried to say this, but it just keeps eluding me. So Peter, you might want to jump in and say this one, methotrexate.
Methotrexate.
There we go. That was nearly what I said. It's a cancer and autoimmune disease drug, and aspirin can actually make it harder for the body to eliminate the drug that they're on for their cancer treatment. And if the body's not eliminating the drug, then what will happen is toxic levels will build up in the system. So it is quite important that we consider and ask what the patient is taking when we're looking at giving aspirin. Selective serotonin reuptake inhibitors, or SSRIs, which are commonly also referred to as antidepressants. And again, this is all to do with increasing the risk of bleeding when we combine it with aspirin. And of course, warfarin. And that's because aspirin reduces warfarin's anticoagulation effects and increase the risk of bleeding as well. Now, we're actually only giving aspirin for suspected myocardial infarction. So for us, we would be quite safe in giving this drug because we're not giving it out for pain relief, we're not giving it out for anti-inflammatory effects, and we're not giving it out for its pyretic effects. So for us, we would actually not withhold giving this drug. But if you were working for an organisation that was using it for pain relief, fever, inflammatory response, then this is something that you would definitely look at before you handed over that drug. If we look at aspirin in pregnancy, low-dose aspirin can be used in pregnancy. However, high doses of aspirin do pose a significant risk, specifically at certain stages of pregnancy. So some of those risks that we have to look at when we consider giving aspirin is that we could have pregnancy loss, there could be congenital defects, we do run the risk of premature closure of a vessel in the fetus's heart, and there is an increased risk of bleeding in the brain of premature infants. Now remember guys, this is high doses of aspirin. So again, in the pre-hospital environment, where we only use aspirin for suspected myocardial infarctions and we only give one tablet, this is definitely not something that we're going to withhold because of those risks. However, a patient that is taking high doses of aspirin on a daily basis who is pregnant may certainly need to consider these risks, but it's not something that will affect us in the pre-hospital environment. So some contraindications. Now, adverse effects, we said these are things that might happen. So we would still give the patient the aspirin. However, these are effects that you may see in your patient. A contraindication is something that would stop you from giving this drug altogether. So you would not give aspirin in any of these circumstances. Even if we do have a patient with suspected myocardial infarction. We have 4 contraindications at paramedical services. And again, these are things that you should be learning because this is what you're going to be tested on. So the first one is known or suspected allergies to salicylates or other non-steroidal anti-inflammatory drugs. So before we hand out this drug, we must ask this patient if they're allergic to aspirin or if they're allergic to any other type of NSAIDs. We must ask them if they've had aspirin before, and we also should ask them if they've ever been told by a doctor not to have aspirin. So there are 3 quite important questions that we should start with before we hand this over. We would not give aspirin to a patient where there is known or suspected active bleeding. So let's say, for example, we've had a patient, that has recently had a car accident and they've had abdominal bleeding, or they are possibly having a stroke. Okay, where there's known or suspected active bleeding, we cannot give aspirin. If there's known bleeding tendencies, so a patient that tells you that they've got stomach ulcers, or a patient that's a haemophiliac. Okay, so definitely important to be asking about the history of this patient before we hand over aspirin. And patients under 16 years of age. Michael, can you tell me why we wouldn't give it to patients under 16 years of age? Joy, how about you? Can you tell me why you wouldn't give it to a patient under 16 years of age?
Sorry, my microphone was muted. Because the association with Ray's syndrome, however you say it properly?
Yeah, excellent, fantastic, that's exactly right. Thanks, Joy. So aspirin comes in a variety of forms. We've got an oral tablet that's short-acting and chewable. We've got a gel, which is a mouth gel. We've got suppositories. We've got extended release formulations, and they're enteric coated tablet, so they do take a lot longer to break down. We've got powder and we've got a liquid. Now, as part of Paramedical Services Pharmacology, you will see the dosage listed. And the dosage for us, when we're giving this to a patient with a suspected myocardial infarction, is 300 milligrams chewed and swallowed with small sips of water. Now, again, we always talk in measurements, not in tablets. So we wouldn't say 1 tablet or 2 tablets. We would always talk about 300 milligrams, because depending on the tablet weight, that could be 1 tablet or it could be 2 tablets. So our last slide, we'll just look at some effects of taking salicylate drugs and overdoses or toxic doses. So when we look at anything less than 150 milligrams per kilo, the patient will have quite minimal symptoms. Anywhere between 150 to 300 milligrams per kilo, we'll start seeing some mild to moderate symptoms, so tinnitus, vomiting, hyperventilation. When we start looking at over 300 milligrams per kilo, this is where we start seeing severe symptoms with this patient. And that could be acidosis, seizures, hypothermia. We're starting to see toxic levels in this patient. So a toxic dose of aspirin is 200 to 300 milligrams per kilo, and that's per kilo of body weight. And a lethal dose is anywhere of about 500 milligrams per kilo, and this is considered potentially lethal. This is where we start talking about overdoses in patient. Of course, with children, much lower levels can affect a child. So those toxic dose measurements are for adults, and we must consider lower doses for children. Okay, so guys, that's a bit of a run through on aspirin. What we'll do is we'll open the forum up. Feel free to ask us any questions at all that you may have, whether it be on aspirin or any other drug. It's all yours.
I have a question. I was trying to read through, and you've got drugs in sport. I don't understand what's the difference between prohibited for use in sport and not classified for sport.
Peter, would you be best for that one?
Right. A prohibited drug is that you cannot take it at all. It's actually ASADA will look at it and say that this is a drug that you are not allowed to take, so it may be performance enhancing. If it's not listed, it means that ASADA doesn't have an opinion on it.
Okay, so then you can give it in any circumstance that is deemed.
So all the drugs that we use are obviously used for an emergency procedure or an emergency situation. And so you should never, ever think that just because this person's an athlete, that you won't give that drug. So, for example, if we're at the Ironman series, which we regularly do, and we come across a person who's in anaphylaxis is a good example, or has an allergic reaction, and we give adrenaline. So adrenaline's an enhancing drug for a sports person, all right, but we would not withhold that drug or that medication simply because it's not seen as it's prohibited, for example. So we would give the adrenaline in this case.
Okay. So what organisation was it that chooses whether they deem it allowed to be used in sport?
SADA.
SADA.
Thanks, Joy. Anyone else, guys? Any questions that you've got that have been building up? Who's coming up to their level 3 pharmacology?
Yeah.
So Taylor, Daniel, Michael, you guys are all coming up to your level 2 pharmacology?
Yeah. Yeah, just about to start, yeah.
Yeah. Seriana, you'd be coming up to level 3?
Oh, wait. Oh, yeah. But I haven't really started studying the trees.
Start now. You'd be surprised how quickly it gets upon you.
Yeah, I've literally just started to go more in depth for the level 3s, and I'm like, oh no.
So Taylor, any questions that you've got on the level 2 since you've just started studying them all?
Nothing that's come up yet.
Yeah, Daniel.
I definitely found it easier to understand what the effects and everything were once I actually broke it down into simple words.
Excellent. Yeah.
I just was quickly flipping through. What's is just the potency the difference between dextrose 5 and dextrose 50? Just dextrose 50 is stronger? Is that the main difference?
Chris, do you want to take this one?
Yeah, it's just the makeup of the dextrose itself. So you got 50% as opposed to 5%. So it's just the strength of the dextrose itself.
Okay, that's what I thought. I just wanted to check.
Mm-hmm.
Yeah, and the 50% is very it's like syrupy. It's very thick. It's almost like pure sugar.
Yeah.
What is Wernicke's I cannot say it properly.
Encephalopathy?
Yeah. It says in alcoholics with thiamine deficiency. Why is that an adverse effect for dextrose?
Cole, would you like to jump in on this one?
Hang on, is that better? I'm actually not sure of that. Oops.
Okay.
Yeah, look, Chris, can you remember?
I think it's to do around the high sugar load in it that has the effect on the vitamin, the thiamine.
Yeah.
Yeah, it's its ability to absorb the nutrients. It's a deficiency that dextrose exacerbates when it's administered to a patient, right? So you can overload them with dextrose by giving them a larger bolus in pre-hospital. So if they can't absorb particular nutrients, and that's what that particular disease does, then you're only introducing, I guess, more detriment to the patient than you are benefit. So when you look at the word contraindication, look at the type of drug you're administering, and then have a think about what it will be contraindicating, i.e., what is it that's wrong with the patient in the first place that's making it difficult for you to administer? So I did a bit of research on that particular diagnosis, hence I know why and how the issue is within the patient. But just think of it that way. If it's got a contraindication, there's definitely some sort of deficiency within the patient.
Particularly the alcoholics, they have that liver deficiency anyway, so the metabolism, the way it breaks it down, it's a lot harder for it to actually break down and metabolize.
Now, I'm just looking at the dextroses. I've got no contraindications. Am I missing a page, or is there just no contraindications for both dextroses?
No, so there's no contraindications for it, but it's something that you just need to consider. Okay, so you wouldn't withhold dextrose because of the reason you're giving it. And remember, we're giving dextrose so that the sugar can continue to get into the body and the brain can continue to undertake cellular metabolism. So there's no contraindications. However, we definitely must be aware that in alcoholics, and unfortunately for the most part it is in alcoholics, it may precipitate Wernicke's encephalopathy.
I've definitely given some thiamine anyhow if that's the case.
Yeah, exactly.
In the hospital, so
yeah.
Sorry, it's just one of those things you just need to be a bit aware of, that it can have an adverse effect on the patient if they're, if they're alcoholics.
Yeah. But definitely not something that we would withhold because it's not actually a contraindication, but it would be part of your handover for the history of that patient when you go to hospital, most certainly. Yeah.
So how do you think the patient presents with Wernicke's? What does it look like? How are you going to recognise someone with Wernicke's? Because an alcoholic may not have Wernicke's encephalopathy at all.
To be honest, I just read it and was like, what is that? Like, I haven't actually researched what like Wernicke's I can't say it properly actually is, so I have got no comment on that.
I mean,
how about you email me tomorrow, Joy, with your answer?
Oh, okay. I'll write it down. What is Wernicke's?
Taylor or Daniel, can you help her out?
No, I've got no idea. I looked it up briefly, but I didn't look anything into it.
Okay.
So as Chris indicated, I mean, essentially it's a thiamine deficiency, and the patient will actually present with a triad of clinical conditions. Probably the most common you'll get is what they call an ophthalmaloparesis or a nystagmus, which is an eye movement, and they'll take on this ataxic gait, if you like. The way they walk is very clinically a great clinical example of WE, and the third part of in the triad is actually confusion with the patient. So if you've got all three of those, you can suspect WE. The issue we have, and obviously I'm sorry I was on the phone earlier, the issue with the thiamine deficiency, if we actually give dextrose and we give high dose dextrose, i.e. 50% dextrose, it actually causes a release of more thiamine, which the patient can't afford to use up. So it actually causes a significant syndrome in the patient, which really affects their peripheral and central nervous systems, and that's the big indicators of WE.
So guys, I did pop that triad of signs that Peter mentioned in the meeting chat. So if you jump on and have a look there, you'll see those three signs that Peter has mentioned up there for future referral. Any Any other questions, guys? Seriana, anything that we can help you with tonight?
No, like no questions so far at least.
Daniel, anything we can help you with?
All good so far. All good so far.
Excellent. Taylor?
I'm all good at the moment.
We'll keep studying, guys. Joy, any further questions before we leave you guys?
The aspirin PowerPoint, are we going to be able to find that on Canvas so we can like re-go over it and that?
Yeah, so because I've recorded it, what will happen is I will put it on YouTube and I will send you guys the link like I did with the one from last week.
Okay, sweet.
Yeah. So that'll be up for everybody to go over. And we're going to do these fortnightly. So eventually there'll be a collection of every one of our drugs with live discussion on them and a PowerPoint relevant.
What was last week's drug? Sorry, I missed that one.
Last week was theory. So every second week will be theory and every other week will be pharmacology.
I'm going to have to go. I've got to work.
Can I ask a question?
Yeah, of course you can, mate.
Thank you.
Hello?
Yeah, go for it, Seriana.
Okay, because I missed the first 5 minutes of this meeting, so I don't know if like was mentioned there, but okay, so you know how it is antiplatelet and it limits that ability for the platelets to stick. So does it dissolve the platelets that are currently blocking the artery, or does it only prevent any further?
That's correct. That's a great question, Seriana. So any clot that has already formed will not be broken down by aspirin. It will stay in situ, but there will be no ability for any further platelets to come and increase the size of that initial clot.
Okay, awesome. Thank you.
No worries. Great question. All right, guys. Well, thanks for jumping on tonight. We'll be running sessions every Tuesday or Wednesday, and yeah, make sure you jump on for next week when we talk about theory.
Thank you.
Okay, good night.
Have a great night, guys.
You too.
Thank
There you
you.
go.
Good night.